And is the screen visible to you guys?
Yeah.
Okay. So let's start. Please let the people in because I cannot see waiting in the room. So this is the first case. This is a 56-year-old man who is admitted in the oncology ward for uh, chemotherapy. He has a background of pancreatic cancer and he has done some bloods, and the blood shows that the full blood count is 80, platelet count is 60, and white cell count is 12. Mhm. This is power 10. And this is power 50. Right. So
Drawing platelets there.
the blood can goes to the lab scientist. What do
Yeah,
you think?
you can see there's drawing platelets, thrombocytopenia maybe. Yes, we know thrombocytopenia. A lot of schistocytes maybe.
Histiocytes are quite a lot.
Hmm.
So you have noted thrombocytopenia, noted schistocytes. This thing is here as well.
Nuclear RBC.
RBC. And there are some other changes in the red cells as well.
Two target cells.
Yeah. Someone is typing in the Teams, but I cannot see the Teams. So because I'm sharing the screen, if you can shout out.
Could be something like a TTP, MAHA, some form.
So you're suspecting Maha and TD.
Could be.
So
Let's
what would you
see
do?
if a few more maybe nuclear RBCs. But there's a lot of schistocytes about.
So what would you do then?
I think we'll do a retake on this chop.
Mm-hmm.
And DAT.
Mm-hmm.
To spherocytes maybe.
Right.
Yeah, I definitely refer it to a consultant. I'm a bit concerned about the schistocytes. And
Yes.
there's nuclear RBC there as well.
So you're thinking about Maha and TTP, and you would like to refer this to the consultant hematology or registrar.
Yeah. I'm a bit concerned about the schistocytes.
Oh. Now we need a consultant hematology or registrar hematology to report this blood film. Osman Nasir is first on the list. You cannot be silent because your lab colleague is saying that this is TTP. You need to report this blood film urgently. Second one is Rubina S on the list.
Okay, very shy, Amir.
Yes, I'm surprised that this is life-threatening situation. And
Assalamu alaikum, sir.
awesome. Yes.
Yeah, I can report, no problem. Yeah, okay. So this is a blood film show anisobiculocytosis um, with many schistocytes and um, a few hypochromic cells, target cells, and spherocytes, very few spheros also, and nucleated RBCs. And WPCs are normal in number and morphology, and platelets are reduced. And the blood film findings are suggestive of MAHA slash TTP, most likely TTP, as patient history secondary to malignancy or treatment. Um, for confirmation, um, urgent, we need to inform the clinician as soon as possible, immediately, to confirm
You are the
with the
clinician,
TP
right?
consultant. Yeah, yeah,
You are the consultant or registrar
yeah.
hematologist.
We will call the TTP consultant to confirm the diagnosis and further to start the treatment as soon as possible, and arrange the um, blue light transfer to TTP center in case of TTP for plasma exchange, and send ADAM-TS 13 before it.
Okay. Anyone else who differs with Shabana?
Yeah, I think in malignancy, we uh, will treat the underlying cause.
Okay. Ravia, what do you say? Azza,
Sorry, but I joined a couple of minutes late, so the scenario I didn't hear it from the start.
this is 56-year-old man
Yeah,
admitted in the ward,
yeah,
waiting for chemotherapy because he has a background history of pancreatic cancer.
right.
Blood has been done, and the blood shows hemoglobin of 80 and platelet count of 60, white cell count of 12. The blood
What's
film
a
was seen, yeah, the blood film was seen by the biomedical scientist
yeah,
consultant,
yeah.
and he thinks that this is TTP and MAHA. That's why he referred it to you urgently.
All right. Okay. So I agree with my colleagues in terms of the findings of the red cells. There is an encephalocytosis with many fragmented cells and many target cells as well, and nucleated RBC. Um, there is also like the giant platelets, reduced platelets with giant one and aneuploidy. This is what I saw so far, and neutrophil looks normal. Um, my impression it's there are also a couple of teardrops as well. So it is there is MAHA, but I think it's not might not be TTP. It's could be due to medication induced, maybe. Um,
Okay.
MAHA
Thank you.
because of secondary malignancy and medication induced.
So you think that this is not TTP?
Yeah.
No. We will ask Sami Saleh as well, and then I will discuss it. What do you think, Sami?
Yeah, I agree with my colleagues. Feature suggesting MAHA, so we need to find the cause. So we usually send ADAM13 in this situation, and that will give us an idea: is it immune or not immune? If ADAM13 came back normal or more than 10%, so this can rule out TTP. So usually this discussion will be with the TTP center in line, and then we can decide the second stage of treatment
Adam
depending on.
TS13 came back and it is less than 1%.
So this is TTP then. So we need to urgently transfer the patient. We are not a TTP center, so to TTP center and start treatment as soon as possible. Usually,
Oh, right. So this is a 56-year-old man, and he has pancreatic cancer starting chemotherapy. Okay. There are a lot of fragments in the blood film. Do not forget to mention other red cell finding as well. And this film shows target cells as well. And we had seen whole jolly bodies in this patient as well. We need to mention all the findings that are present in the blood film because it may be written on the key of the examiner. If you do not mention target cell, they may deduct a mark from you. There are macrocytes, everything is there. This patient has pancreatic cancer and there is a MAHA. If the renal functions are abnormal, Shabana said that we will confirm this with TTP consultant. We do not confirm with TTP consultant. We agree on TTP diagnosis with the consultant. If you open the TTP algorithm, it says agree with the TTP consultant because you don't have Adam TS13 when you are calling the TTP consultant or TTP center. You agree on the diagnosis. Yes, this is TTP. Okay? Renal functions are abnormal. There is new anemia, new thrombocytopenia. Yes, this is TTP. But what type of TTP? Is primary or secondary? With the background of pancreatic cancer, this is secondary TTP. And in secondary TTP, yes, we do send Adam TS13 level, but we do not wait for the result. But here, because it is secondary TTP, we do not do plasma exchange. We focus on the secondary form. If it was a primary TTP, then yes, I would have blue light this patient to the TTP center. But if there is a secondary cause present or there, then we do not do plasma. This is how they would trick you in the exam. Reading the scenario is very important.
Yeah. Sorry, Amr. I think my impression was they are secondary TTP, but like is that before even the Adam 13, we would also like check the clotting and the hemolysis screening, for example, and kind of we're not using it, but like the plasma score that could give like a clue, if it's like a primary or secondary, and in terms of when you mentioned the history about the second like malignant pancreatic cancer, I thought like it's probably secondary. So no, not for plasma exchange, yeah.
If this patient was post-allogenic stem cell transplant and he is using tacrolimus, the picture is like this. Okay, it is also MAHA. You may be thinking of TTP as well. AWTS13 may be less than 10%, but he is post-transplant and he's using tacrolimus. This is drug-induced. you will not plasma exchange it.
Yes. Yeah.
They can give you this picture with normal platelet count, but the picture is just like this. A lot of red cell cystocytes and hemoglobin is 90.
I'm not sure, Amir, but I got a patient similar to this story post-transplant, and his Adam-13 was 50.
50,
So
yes.
so I'm not sure if the Adam-13 is like below 10%, how how we say like plasma exchange is not indicated.
Because there is a secondary cause present over there. It is not immune. You do plasma exchange to remove the antibodies.
Yes, so Adam-13 will be how will Adam-13 will be replaced? I guess when we have Adam-13 below 10, we need to check for Adam-13 antibodies first, right?
Yeah. So, for example, if it is tacrolimus related, we stop tacrolimus. We change it to sirolimus. We change it to cyclosporine. If it is pancreatic cancer related, then we start chemotherapy for the patient. Yes, the patient will have low ADAMTS13 levels for a few weeks before the chemotherapy kick in. Then the ADAMTS13 level will go up. But the plasma exchange will not change anything. In pancreatic cancer, in tacrolimus-induced TTP, or any other cause of secondary TTP. In the primary, it is the antibodies, and the purpose of the plasma exchange is to remove the antibody that is nullifying the ADAMTS13.
Sir, I have a question. In malignancy, Adam TS13 will be low. No, it will not low, right?
In most of the cases, it is not low, but in some cases, yes, it gets low as well. Pancreatic cancer is a mucinous cancer. It absorbed everything.
Okay.
And most of the secondary TTP you will see in pancreatic cancer patients.
So in that case, we just treat the malignancy. We will not treat.
We do not
go
do
for the
plasma.
plasma
Plasma
exchange.
exchange is only for primary TTP, not for
Yeah.
second.
Yes.
It is mentioned in the guideline, clear cut. BSH 2020.
Sorry, Amir, this is Kali. I am with Sami. Yes, I know that that case was sent from our center to referral center. That one, like allograft patient, something. But we know that there are poor response. But what is the guideline suggestion about Keplacizumab use upfront in case if we are trying to liberate or release the platelet in circulation to prevent any bleeding complication?
We transfuse them. Like
Okay,
here in Leeds, we have a big allogenic stem cell transplant center as well. We find this situation quite often. Um,
right.
if the patient is not responding by changing the immunosuppressive therapy, then MDT usually decide for blood transfusions. If no response, then sometimes they decide about either rituximab or eculizumab.
Okay,
So this is an MDT decision, but there is no guideline for separate guideline for secondary TTP.
correct.
Because
Correct.
we quite often face this phenomena of MAHA
Yeah.
post-transplant or TTP post-transplant, and their ADAMTS13 levels are low as well.
Yeah. So we can immediate because we do show some quick response. Like in that case, shall we consider like methylpred or retux up front? Because if we show like TTP directed therapy, because we know that TTP platelet transfusion is relative contraindication, lots of hey ho around the community. So I was just wondering on this point, please.
Uh, if a if a patient is bleeding, okay, then
Yes,
you have to give platelets. If the patient is not
correct,
bleeding, then
correct, agree.
You have to
Agree.
wait.
Yeah.
And methylprednisolone, I think in post-transplant patient, consultants usually avoid steroids. Especially in my center, they do not give. They try to avoid steroids post-transplant because they
Okay.
are already immunosuppressed.
Okay.
Steroid doses of steroids or pulse steroids may make it more immunosuppressive.
Yeah. But again, I have little bit of hesitation in that point because of, when we do see the graft versus host disease like GARD, GVHD, so on and so forth, then we end up offering steroid.
That
So
is a separate thing then.
different. Okay, yeah.
If a patient develops GVHD, then it is
Then
a separate. Then their treatment is steroid.
okay, okay. No, nice information. Thank you.
All right. This is a second case then. All right. So this is 15-year-old boy referred by the GP due to anemia. So in the hematology clinic, he did some bloods. Hemoglobin is 110. Platelet count is 161, and white cell count is 9. This is the power 10, and let's go to power 50.
A lot of anecytosis there. Spherocytes. That really is a DCT and reduct count.
To give you
Possibly
more
autoimmune.
information, DCT is negative.
It's negative. Okay. Well, the retic count done?
Platelet count is high.
Okay. Was it a reticulocyte count done though?
Yes, retic count is done, and they are high.
Yes. Right. It looks more like an autoimmune problem. Lot of spherocytes. The HB was okay though, wasn't it?
Yes, 110.
Yeah, a lot of anecytosis there. Tuberculocytes.
There are a lot of things in this one picture.
Interesting film.
And he's 15-year-old.
Yeah.
So what do you think? You think this is some hemolysis going on, autoimmune?
Yeah. It's not many. You can't see any nuclear RBCs, but there's so many spherocytes going there. Say it's a form of autoimmune, or maybe yeah. There's no any lymphocytes around.
White cell count is okay, and lymphocyte count is okay as well.
Yeah. Thrombocytosis. There could be a bleed as well going on.
No, there is no
I
bleeding.
definitely refer this one Ahmed anyway because I'm concerned about the number of spherocytes.
Okay, got a lot of spherocytes in this one and other findings as well. Do you think this patient is bleeding or something?
Could be a form of hemolytic. like I say, there's not that many nuclear RBCs about, but the spherocytes is concerning for me. I don't know whether it's a HS or not. Or autoimmune. HS possibility.
Okay, you think this is FS. Okay. Clinical hematologist? What do you think?
Assalamu alaikum.
Islam?
Can be, I have a differential for this peripheral phlegm. It can be, can it be membranopathies?
You need to report the blood.
Okay. So the RBC, there is severe anisopoikilocytosis, and there is oval macrocytes +2 +3, and along with leptocytes, spherocytes, macrospherocytes, and few pencil cells. Platelets are adequate on peripheral smear, but I haven't seen any WBC here. So conclusion is it can be membranopathies. By keeping history, it is hemoglobin is around 8, so it's not severe anemia. Yeah, this is, I think, lymphocyte.
So how much Jolly body's about, I think.
Yeah, Howell Jolly body is there.
It's more like a HS to me.
Few fragmented RBCs, teardrop. So conclusion is maybe it is a hereditary pyropoikilocytosis or hereditary leptocytosis is a differential. I have. So advice for the EMA, phosphatic fragility test, and STS page, and family studies and genetics. CBC along with other parameters like MCV, MCH.
You're right. This is HPP. There is some
Sorry?
Yes, this is HPP, hereditary pyropoikilocytosis. You can see a wide range of red cell features here. If it was electrocytosis, there should be no spherocytes here, and no teardrop, and no histiocytes, etc. But it has macrocytes, spherocytes, teardrops, some strange histiocytes as well, and isopoikilocytosis. And all of the blood film is like this. So this goes with the most likely membranopathy, the hereditary pyropoikilocytosis. But you need to confirm that on investigations that you have mentioned. This patient has whole jelly bodies as well. Do not forget to write it in the exam. Because this blood film can be given in the exam in a different way as well. Write 6 different features present in this blood film. They may not ask you to report it. They may ask you write 6 features from this blood film. This blood film has a lot of features. So this is hereditary pyropoikilocytosis, and you need to confirm that on genetic testing. That's why he was not that much anemic. He will get anemia only in stressful condition.
Right.
This is an equal slide. Those working in the NHS, they should go to the lab and see the NICO slide for HPP. It appears in the exam. The next patient is a 21-year-old female. He is feeling generally unwell. This is power 10. Her hemoglobin is 130, platelet count is 180, and white cell count is 16. This is power 10. Okay. Now power 50. Yes, what do you think, Mark? I think you are the only biomedical scientist here. Any biomedical scientists? Mark, Abhi? Okay. For example, I am the first year biomedical scientist. I have seen this blood film and I have seen a lot of atypical white cell, and I think that this is ALL. Okay. And I have referred this blood film to you guys, to hematology registrars and consult. So please report this blood film. My suspicion as a first year biomedical scientist is that this is ALL because of these white cells. Denusha, can you speak up, please?
Yeah. Red cells, nomochromic, normocytic, and there are some alveoli bodies. White cells, lymphocytosis noted. There is reactive lymphocytes with abundant cytoplasm, bluish abundant cytoplasm. Some showing flowing cytoplasm flowing around the red cells, making red cell indentation from the cytoplasm. Cytoplasm making red cell indentation. Platelets are I didn't see the neutrophils. Nucleus show some chromatin clumping. And platelets are normal. So I think this is more like reactive lymphocytosis, most probably due to mononucleosis, infectious mononucleosis. I will do Paul Barnett IMN antibodies and CMV, IgG and IgM antibodies. And as there is evidence of hyposplenism, to assess further investigations to see, or I don't know, ultrasound scan abdomen to see liver, spleen.
You do hepatitis B, C, and the HIV as well, along with the monospore. But I am a first-year biomedical scientist. I was thinking this is ALL. So how will you tell me that this is not ALL, blast, these are reactive lymphocytes?
Because the morphology, there is nuclear, the nucleus appearance, the chromatin, there is chromatin clumping, and there is no evidence of like immature nuclear material.
But they told me that this patient has cervical lymphadenopathy.
Which can be which is a feature of infectious mononucleosis. They can have lymphocytosis, mild splenomegaly, mild hepatomegaly.
Okay, that's right. Yes, you are right. These questions quite often come in the part 2 exam, and people make it ALL because ALL is common in teenage. So when they see a patient of 21-year-old, 20 or 19 or 18 with with such blood features, they think that this is ALL. But here's the atypical lymphocytes. They have mature nuclear material, and cytoplasmic material is a bluish in color. Sometimes they make scalloping to the red cells. But remember, scalloping is not a feature of infectious mononucleosis or reactive lymphocytosis. You may find scalloping anywhere where there is high white cell count. We had seen a monoblastic AML, whose slide is present in the morphology quizzes on the channel. That patient has white cell count of 132, and there were quite a lot of red cell scalloping. Okay? So it depends on a scenario, white cell count, and then yes, you can say there is a red cell scalloping, but it does not necessarily mean that this is a reactive lymphocyte. 132 count cannot be reactive lymphocytosis. And if a patient has intracranial hemorrhage as well, and the blood film shows a lot of atypical lymphocytes with scalloping, you cannot say this is a reactive lymphocyte. It depends on the scenario that they have given you, the patient that they have given you in the scenario. Yes, these lymphocytes are quite reactive looking. The cytoplasmic is blue, nuclear material is yellow. This is infectious mononucleosis. Every alternate epilepsy path exam has one slide about infectious mononucleosis. The next line is a 40-year-old female who is admitted because of um, bruising and progressive tiredness. So, the hemoglobin is 94, platelet count is 80, and the white cell count is 9. Go to column 50. Second. This is power 50, and and these are the few white cells available. Any biomedical scientists that want to comment on the blood film feature? No? Oh. So again, I am the first year biomedical scientist. I heard from Dinusha that if the cytoplasm is bluish, then sometimes they are reactive lymphocytes. So these cells appear to be bluish as well. So I have labeled it as a reactive lymphocytosis as well. But then for a second opinion, I referred it to you guys, to clinical hematologist and consultant to see what is this. Okay, what do you think? All right, so any clinical hematologist?
Oh, yeah. So the blood film is showing anemia. Um, um, there are medium to large size mononuclear cells with nuclear with bilobe nucleus, agranular cytoplasm. I and there is thrombocytopenia, so I couldn't see any platelets here. um, yeah, bilobe nucleus and agranular cytoplasm. Um, and nuclear chromatin looks open nuclear chromatin. Couldn't appreciate any nucleolus. And the patient presented with tiredness, I think, presented. So I would think about APML here.
Anyone else with a different opinion?
Sir, we will write that the blood film shows atypical mononuclear cells, blast cells, that are medium to large in size with abundant cytoplasm, open chromatin, and open chromatin nuclei, and with prominent nucleoli, basophilic cytoplasm, and red blood cells is an isopoikilocytosis with normocytic, and platelets are reduced. So yeah, we will say it's the findings, blood film findings are suggestive of acute leukemia, most likely acute myeloid leukemia. And for confirmation, we will go for the flow cytometry and bone marrow with the cytogenetic and fish analysis.
But your colleague mentioned APML.
It's not a typical APML.
So this is ALL or AML? How can you say this is AML? You mentioned this is acute myeloid leukemia. How can you say AML?
Sorry, Amar, what is the question?
This is AML or ALL?
Right, likely AML.
Why? Why this is AML?
Right, so the size of the blast, it's kind of tends to be large, medium to large in size, and in terms of the nucleus, it also like it's very open, like chromatin, rather than compacted chromatin. What we can see in the lymphoblast, there is nucleolus in few of them. The cytoplasm is not, yeah, it's not granular. It's not like it tends to be granular in the like in terms of myeloid, but it's not here. It's agranular, but like it still could be either monocytoid or yeah, it could be monoblast rather than still. I don't think it's yeah, lymphoblast. This is the main things I think.
Yeah, but some features favor lymphoblasts, like less number of nucleoli, more regular rounded shaped blasts, and uh, bluish cytoplasm. This favor ALL more.
Mm.
AML blasts are like quite large, abnormal shaped, and the nucleus shape is also more abnormal. And they have like multiple nucleoli, so that is against that features we don't find here. So it could be ALL also.
Mm. It looks also like monoblast for me. I don't know. Maybe AMML. I'm not sure. Or M4. I'm not sure.
Have you got any immunophenotyping result?
Sorry?
Have we got any flow cytometry result?
No.
I think these are myeloblast, not lymphoblast.
Why?
Nuclear chromatin is not suggestive of lymphoblast. It is like a reticular nuclear material.
In lymphoblast is a high NC ratio, but here is a patent cytoplasm, and so it's more suggestive of AML.
Ramir, we can send the anti-PML thing. It will come within 1 hour maybe.
Or it could be mixed phenotype, acute leukemia. Mixed phenotype, acute leukemia can be possible.
I think also the polymorphism is more in myeloid lineage rather than lymphoid lineage. So in ALL usually is monomorphic plus.
That's why on the blood film, you always say that this is most likely acute leukemia. You do not say that this is AML or ALL unless you are very sure. But you may have seen that your seniors or consultants, they always mention for a blood film like this is acute leukemia. We need urgent flow cytometry on peripheral blood to find out the lineage, that this is ALL or AML. Then yes, the rest of the things you will do bone marrow biopsy on this patient, or if there is a lymphadenopathy, you may do lymph node biopsy if a patient is refusing bone marrow. But this patient has cytopenia, so bone marrow biopsy is the next step. But the first thing we do is to take blood sample, drop it in HMDS, ask them to give us a provisional flow result to see whether this is myeloid or lymphoid. These cells have a lot of cytoplasm. The cytoplasm nuclear ratio is not very low. In lymphoid cells, they have very minimal cytoplasm. But here, the cytoplasm is quite a lot. Some of the cells have granules, not all of them have granules. And I was looking for a cell which has our rods. In this blood film, there are few white cells which contain our rods. But when you try to find them again, they are lost. The end result of this slide, this patient is currently admitted with us, is the flow cytometry matches AML, and this patient has many different mutations, so we label it as complex karyotype AML. All right, so never say that this is AML or ALL on a blood film, just mention the most likely this is acute leukemia, needs urgent flow on peripheral blood to find out the lineage. The further investigations will be bone marrow biopsy for cytogenetics, immunophenotyping, etc.
Sir, if you don't mind me asking why the RBCs in the background dish are looking like this, like two RBCs are stacked in most of the films, most of the fields that we saw, two RBCs were stacking together. Is there
I'm
a
on the
reason for that?
I'm on the thick side, that's why, because I'm searching for a blast which contain our rods.
Okay, okay.
If I go to the thin side, then they will be one and one cells, not stacked cells. Mhm.
Sir, I have a question.
Mhm.
Okay, I was just thinking that the patient's history was oozing from many sides. She was 40 years old female. Although the TLC count is not very high, it is around 9, but some of these cells do show those nuclear foldings with abundant cytoplasm, and occasionally we have shown us are showing these OR rods. Can we give the possibility of APML also in it? Can we write like in our report that urgent flow cytometry on peripheral blood?
So if you have seen the cells of the NPM1 related AML, their cells also sometimes shows holdings that make you think that they are APML. They are actually not. The
Mhm.
APML cells, they have two bilobe nuclei that are very characteristic. Like this one, this cell which is present on the screen, if you tilt it a bit, you will
Yes.
think that this is like a bilobe cells. Actually, this is not a bilobe.
Yeah, it's not. It's kind of a nuclear indentation.
Yeah. So,
Yeah.
and then secondly, our road can be present in other um, hematological malignancies as well. A type of MDX contains our roads as well. Sometime the inversion 16, they will contain our roads as well. So our road is not a classical features of APML. You can find them in other conditions as
Yeah, but oozing from many sites, that was also part. So I
well.
actually I was stuck on
Yeah,
APML.
oozing, maybe the patient has thrombocytopenia. That may be the cause.
Right.
Yeah.
So, sorry to interrupt again. I mean, I was wondering, like nuclear indentation or the cupping of the nuclear shape, which seems mimicking bilobed. So, is it the DD for NPM1 mutation as well here in this case, if it was detected or not?
So you do not write NPM1 as a DD. We only say acute myeloid leukemia or ALL or biphenotypic leukemia if they ask you about differentials. NPM1 mutated is like you are going too deep in the subcategories of AML. When you are sure this is AML, then you will say the nucleus has a cup shape or fish mouth shape materials. This can be NPM1 mutated as well. But you do not give NPM1 mutated AML as your differential. You always wait for the cytogenetics to come back.
Yeah. No, out of curiosity, as you said, like as it was a complex karyotype AML at the end in your
Mhm.
center. So what was the NPM1 status? That's out of
Uh,
curiosity.
and it was not mutated.
Okay, okay, thank you. Thank you.
Primer,
It was
if we put
TP53 mutated, KMT2A mutated, and there were two other mutations. Uh, but the patient has 4 or 5 different mutations. Yes? Someone was asking about.
yes, the primer, if we put AMPL as a differential,
Mhm.
if we put APML as a differential, will it deduct our mark?
No, they will not deduct your marks. But if you mention, answer the rest of the questions as APML and their key answers are different, then obviously they will deduct marks. And I should bring APML slide now for you. this will be our last slide. So this is a again young patient with epistaxis. These are hypergranular, and let's find the typical APML cells. This one, they are bilobe and granular as well. Do they look different than the previous blood film? Especially
totally
the
different.
lower ones, especially this one. These are two different lobes. This is one lobe, and this is another lobe. Another typical bundle cell. This is a bean-shaped cell, not classical bilobe cell. This one is a typical bilobe cell. Does it look different than a previous blood film?
Yes.
Yes.
Yeah.
Oh, these look different. This one is figure of A, and these are two different lobes. One is this one, and the top one is separate. You can see the marking. The hypogranular variant, they are usually pancytopenic. You will not see a lot of bilobe cells in them. It will be one or two only.
Sorry, hypogranular variant is with high TLC, I think.
The most of the hypogranular variant, I have seen are with low TLC. Yeah, they can come with high TLC, but the one that we have seen, they have low TLC, and we had missed them as well. We found out only on bone marrow biopsy investigations. It has been reported by HBS that this patient has APML.
But as I read that most of the hypogranular variants presented with higher TLC as far as 4 lakhs.
Mhm. I
So that's
agree
why,
with you.
yeah, and that is the difficult differential with the monocytic AML, because
Mhm.
that is hypogranular variant and as well as 2 to 3 bilobed as well.
I think no one can miss this bilobe cells. You see this one as well, you will think that this is AML, sorry, APML. Searching for another bilobe cell and then will conclude. And is this look different to you guys?
Yes, it's totally.
This is figure of 8. And these are the two typical bilobe cell. This is a separate lobe, and this is a separate lobe. And they are hypergranular. I hope you will not miss APML in the exam, because if you miss APML in the exam, they will miss you as well. They would like to see you again in the exam. Right, so this was the last case. If you have any question, shout out.
Thank you very much. Thanks a lot.
A lot of things in the Teams, but I cannot see Teams during the session. So, so thank you very much.